Good morning, students. In further continuation to my last class on coronary artery disease, it's also known as coronary heart disease or ischemic heart disease. Today we shall be talking about the prevention and control of coronary artery disease. In my last class, we had spoken about the prevalence, incidence, the global burden and various risk factors. Today we shall be talking on prevention and control of coronary heart disease and also many intervention trials which are internationally acclaimed or which produced certain results which can be applied to the general population also will be discussed in the lecture. What we know about the coronary artery disease so far, just to recapitulate what we discussed in our last class, that's the features and clinical manifestations of coronary artery disease. I discussed about it that coronary artery disease mostly manifests as angina pectoris, that is the periodic chest pain. Sometimes it is a central chest pain, acute pain, and there is ischemic heart disease or myocardial infarction. Sometimes it can be just a silent death, you may not come to know, but later on post-mortem the disease, the diagnosis comes out to be coronary artery disease. There can be ventricular arrhythmias like ventricular fibrillation, ventricular flutter, or atrial fibrillation and atrial flutter. There can be cardiac failure. So these are the main features or clinical manifestations of coronary heart disease. The global burden, I spoke that coronary heart disease is a big problem all over the world, and approximately 12 million people, 7 million people who die of different causes all around the world, out of which 12.8% is the contribution of coronary artery disease, which you can easily estimate that approximately 85 lakhs of people all over the globe die due to IHD or myocardial infarction. If there was no coronary artery disease, the life expectancy could have increased by 3.4 to 9.4 years more for all the people. Third point we discussed in our last class is the epidemicity of coronary artery disease in developed and developing countries. In the developed countries, the coronary artery disease started in the form of epidemics. Many people were suffering from myocardial infarctions and ischemic heart disease somewhere in 1910 to 1920. By 1940, they studied the disease. Many scientists worked on the coronary artery disease and found out the reasons, and they started applying the lifestyle modification and reformation policies, and thereby somewhere in 1980s, the developed countries controlled the coronary artery disease, and we can see now that there has been a 25% decrease in the mortality rate due to coronary artery disease in most of the developed countries like Australia, USA, Canada, etc. The global mortality burden is also quite high. As I have told that out of the 7.2 million people who die due to different reasons all over the world, the coronary artery disease contributes to 12.8%. That in the number of figures it comes out to be around 85 lakhs per year. Out of this, there are the large number of people the large number of people suffer from the Eastern European countries. In the Eastern European countries, the total number of deaths due to different reasons is around 2.1 million, of which 30% die due to coronary artery disease. This is one sector where the coronary artery disease could not be controlled because of various reasons, and the epidemic is still going on. The second region followed by this is the Southeast Asian region of WHO, that is the Indian subcontinent, where the total death due to different reasons is around 1.8 million, and of which the contribution of the coronary artery disease is around 20 to 22%. Next point what we discussed was the morbidity and mortality in India due to coronary artery disease. The morbidity means the prevalence of coronary artery disease, which is around 6.4 per thousand in the urban area and 2.5 per thousand in the rural area. and mortality means the death rate, and the death rate in the urban area is 0.8 per thousand and 0.4 per thousand due to coronary artery disease is the mortality rate in the rural areas. We also discussed about the risk factors. The classification of risk factor is a very common question. It often comes in your examination. So there are three ways of classifying the risk factors. I have already told you the risk factors which are amenable to change or which are modifiable. So modifiable risk factors and non-modifiable risk factors. There are major and minor risk factors. And thirdly, the American Heart Association's classification of risk factors. So please describe all these three when you write the classification of risk factors. The most important is the major and minor risk factors. The major risk factors for the coronary artery disease are the smoking, hypertension, hypercholesterolemia and the physical inactivity, and rest all other risk factors are taken as minor. Whereas modifiable and non-modifiable risk factors, non-modifiable risk factors are the advancing age and the male sex, familial history and the genetic predisposition. These are non-modifiable risk factors, and rest of the risk factors are all modifiable. We had a detailed discussion on smoking, how does it cause the coronary heart disease. We have discussed about the hypercholesterolemia, how it promotes atherogenosis and atherosclerosis followed by blocking of the coronary arteries, and we have also spoken about the hypertension and diabetes in detail in the pathophysiology of coronary artery disease. We discussed ill effects of the physical inactivity. We had also discussed in our last class all the other risks. So with this recapitulation of the last class in a very brief way, now we will proceed to the today's topic, that is the prevention and control. The WHO expert committee recommended the following strategies for the prevention and control of coronary artery disease. The strategies are population strategy, high risk strategy and the secondary prevention. In the population strategy, there is community prevention, there is specific prevention or intervention like diet, tobacco, blood pressure and exercise, and a third count is the primordial prevention. Then there is high risk strategy, and the secondary prevention has got the following components, that is the early diagnosis, medical treatment, revascularization and the lifestyle modification. The population strategy of coronary artery disease prevention. The population strategy is very important because the coronary artery disease is considered as a public health problem. Communities follow the common patterns in the diet, in eating habits, edible oils, tobacco use, and if not, in the physical exercise. If we compare or if we kind of give some example, like say for all Eastern Indian people, especially those who belong to Bengal, Bihar, Assam, Odisha, they are rice eaters. They take the mustard oil, they take fish. So these are the kind of things which are common diet and which is taken by most of the people. So if you have to bring a change in the diet, or if you have to teach them about a special diet, you have to teach all the people to improve a community as a whole, not to improve an individual as a whole. So certain major risk factors of the coronary artery disease often found in most of the communities, and the members may be at risk, maybe in the lower risk or maybe in the higher risk depending on their clinical status of the disease. Population strategy aims at rectification of the lifestyle and bring in a biological normality among the members. The service providers or the strategists, they formulate a population mean, population average. Say for example, population mean decided for cholesterol concentration of the blood is 200 milligram per deciliter, or population mean for the systolic blood pressure, which is most important in precipitating the coronary heart disease, is decided to be fixed on 130 millimeter of mercury. So they try to bring down the population mean to that 200 milligram per deciliter or to 130 millimeter of mercury. And once you can bring it down, the population or that particular community will have 30% to 40% less chance of getting coronary heart disease or getting the cardiac attack. All this can be done through the community awareness about healthy lifestyle, and this should be done through the community mobilization. Community mobilization means the service provider should be able to interact with the community members. Community members should come forward and interact with the service provider, and they should bring down the changes in their lifestyle, try to bring up new methods, and ultimately the community participation and various intervention measures to be adopted to finally reach the goal. So this is the overall strategy for the population strategy for the coronary artery disease prevention. Further, to discuss the counts on the population strategy, there is a community prevention. Community is identified should be under the medical and the health cover. The members need to be informed about the program, highlighting its benefits for the individuals as well as the community members. The community leaders like the religious heads, the political members are to be involved so that they can bring their fans to follow the program. Once preliminaries are completed, the details of the coronary artery disease and its ill effects to be discussed, and those appear to be at risk need specially interacted, and thereafter specific interventions on the diets, smoking, blood pressure and the physical activity for the members are to be instituted. Next in the population strategy comes the specific intervention. In the specific interventions, there are 6 points, the first two being the dietary change and the smoking. The dietary change includes a reduction in the oil and fat content of the fat intake should be 25 to 30% of the energy intake daily. The saturated fat to be brought down to 10%. Saturated fat is mostly available in the butter, ghee and maybe in dalda, one of the saturated fat, high content of the saturated fat. If it is also present in the coconut oil. Cholesterol intake should be 100 milligram per 1000 kilocalorie per day, and it should be maximum 300 milligram per day. Now you see, if we are taking a sedentary diet and our total calorie intake is 1800 kilocalorie per day, then the cholesterol should be ideally 180. Cholesterol intake should be ideally 180. However, one full boiled egg contains around 186 to 187 kilocalorie. So just an egg per day will complete your cholesterol intake for that particular day. It has been seen that complex carbohydrates like vegetables, fruits and grains, they are helpful. They have got lot of fibers, and these fibers, they prevent absorption of dietary cholesterol into the system. So that way the lot of vegetables, fruits and grains are recommended to avoid the coronary artery disease. Avoid alcohol, not altogether, but you can take around 2 small pegs. One small peg generally contains 30 ml of alcohol, so 2 to 3 small pegs are recommended, but not more than that. And salt intake has to come down to 5 gram per day. So you can see there are a lot of restrictions in the coronary diet. First of all, that your fat intake will come down to approximately 30 gram per day, and that way one person per month will be maximum 1 liter of oil you can take. And similarly, the salt intake will come down to 5 gram per day, and that way 150 grams of salt per month. So this is very difficult to continue, but these are the specific interventions which have been recommended by the WHO. Smoking need to be completely stopped. Awareness and education on ill effects of smoking needs to be disseminated. Promotion of no smoking society and adverse effects of the smoking on families and children are to be told. The Smoking in presence of the families and children often cause upper respiratory infections, acute respiratory infections, respiratory distress syndrome. So therefore, the effect of passive smoking on the families and the children are to be discussed so that the individual gets motivated to stop smoking. And sometimes legislative measures are also to be taken, like in institutions, maybe in the college, maybe in the offices, the smoking zones are to be separated and public smoking needs to be prohibited. So these are the specific interventions on these two counts, that is the dietary changes and the smoking. The third point is control of blood pressure. As I told that population mean blood pressure is decided, it may be 130 millimeter of mercury, and if a small reduction in the population mean can be done, then it brings a large effect on the total population. Such reduction avoid the coronary artery disease and coronary incidences gainfully. Ideal population mean blood pressure need to be set and achieved, and the blood pressure reduction by diet, reduced salt intake, physical exercise and avoidance of alcohol are to be initiated. The fourth count is the physical exercise. Awareness and education on the healthy effects of the physical activity needs to be promoted. Promotion of physically active society. The young adults and the children are to be inspired to play games or take runs, and elderly and the ladies are to be inspired to take walks, brisk walk or the evening walks. The last point in the population strategy is the primordial prevention. It is basically a primary prevention. It prevents the coronary artery risk factors to appear in the community. It promotes healthy lifestyle and the lifestyle modification to mitigate the risk individually. It involves community interaction and monitoring. It facilitates traditional eating habits, reducing fat, oil and the salt, and multifactorial approach to reduce the risk at individual as well as the community level involves principles of the primary prevention, risk identification and mitigation by advice and follow-up. There are certain intervention trials like MAFIT, multiple risk factor intervention trial, then Stafford, then Monica projects. There are few of them which actually based upon the primordial prevention and the primary prevention. So with this we finish the population strategy, and next we go for the high risk strategy for coronary artery disease prevention. In the high risk strategy, there are points like identify the individual who are at high risk by employing simple tests, maybe the blood pressure, serum cholesterol, blood sugar and the baseline ECG. This is to be done on a mass scale on each and every community member at a periodic interval, maybe at the 4 months or 5 months, and the family history of myocardial infarction, diabetes and obesity are to be obtained, and physical risks of obesity, smoking and alcoholism are also to be taken into consideration. After the risks have been identified, the risk groups are to be told for treatment of high blood pressure and hypercholesterolemia, and they should be helped to quit smoking by use of nicotine gums or the nicotine lozenges, or maybe by using the nicotine patches on their body. The high risk intervention studies are Oslo Heart Study and Lipid Research Clinic Study. This will be discussed later on. The high risk strategy helps the risk group, but it doesn't help the community, or it doesn't assist in community prevention. With this we come close to the high risk strategy, and now we will be discussing the secondary prevention for coronary artery disease. The secondary prevention has got certain points, like it has got early diagnosis and treatment, then it has got identification of those people who suffered from myocardial infarction, and thereafter their follow-up and treatment, and lastly revascularations. The early diagnosis can be initiated by annual preventive check for the individuals who are above 40 years of age. This includes the ECG, biochemical parameters, blood sugar profile, and stress test, or the MUGA also can be done. MUGA is the multi-gated acquisition test for the heart by use of the stress thallium, by which we can find out the cardiac conditions for ischemia. We can treat certain conditions, like we can use the statins, atorvastatin or other kind of statins to lower the cholesterol level in the blood. We can use antihypertensive. There are plethora of antihypertensives, like there is diuretic, there may be calcium channel blockers, there are beta blockers, there are alpha blockers, and there is ACE inhibitors. So depending on the clinical condition of the patient and the algorithm of the treatment for the hypertension, we can take up the antihypertensives for that particular patients. We can use the anti-diabetics for the diabetic patients. We can use the anti-anginal agents if a patient is suffering from angina pectoris. Then we give the dietary advices, including salt, sugar, oil, and other nutrients. Further, to continue in the secondary prevention of coronary artery disease, we identify those who have once suffered from myocardial infarction. Because those who have already suffered once from myocardial infarction, the chance of recurrence is very high. So therefore, in those cases, we have to identify them and we have to treat them. We have to tell them to smoking needs to be stopped, and quit smoking will bring down the recurrence approximately by 30 to 35%. We have to treat if there is hypercholesterolemia, high BP and diabetes, and we have to promote nutritious diet, physical activity, walking and jogging. The certain specific advices, like if we use beta blockers, we have found that it helps to reduce the second attack by 25%. Beta blockers like atenolol is often used as a cardioactive drug as well as an antihypertensive medicine. So this can be prescribed if it is not being taken by the individual who already suffered from MI. So it can be prescribed, and so that the chance of recurrence comes down by another 25%. Without quit smoking, of course, nothing seems much helpful. So quit smoking has to be emphasized upon, and the individual is to be motivated to leave smoking completely once he has suffered from myocardial infarction. There is an urgency of hospitalization once a person started having a heart attack and there is acute chest pain and the person gets into very serious conditions clinically. So delay in such kind of hospitalizations can end up in fatality. Angioplasty helps if a person reached the hospital or the cardiac center where angioplasty or PTCA can be done within 1 to 2 hours and his life can be saved. But if it is beyond that golden period of 2 hours, then the angioplasty also will not be so fruitful. The time factor, that's way, often subdue the impact of coronary care. Further, in the secondary prevention, the requirement of revascularization. Revascularization, there are two processes. One is the PTCA, that is part trochanteric coronary angioplasty, and CABG, that is coronary bypass surgery, coronary artery bypass surgery, CABG. The PTCA is generally easier and it is common. Indications are angina pectoris, where medical management has failed. Even after giving treatment in a case of angina pectoris, if the patient is getting periodic and repeated chest pain, then PTCA is generally indicated. If there is a left coronary artery blocked, less than 50% with or without symptoms, then also it is indicated. It is indicated in 3 vessels disease, written as 3VD, with the ejection fraction EF less than 50%. It is also indicated in unstable angina or ischemia on stress test or Muga test, and it is also indicated in post-MI angina. After having myocardial infarction and a heart attack, even if the person continues to have angina, then there is a requirement to do the revasculation procedure. CABG, that is the coronary artery bypass graft in healthy patient, has just 1 to 3% mortality rate, whereas PTCA is very successful and it is very effective procedure, and it can be done within within 1 to 2 hours of having a heart attack, and even during the process of PTCA. It is often known as the balloon angioplasty, where that PTCA tube is put inside the coronary artery and the balloon is inflated so that the coronary artery opens up again, and then if there is any stenosis or if there is any kink, then we can put up a stent to avoid the restenosis and rekinking. With all this, we have spoken about the prevention, control, treatment and diagnosis of coronary artery disease, and now I shall be talking on certain risk factor intervention trials all over the world which are renowned and internationally acclaimed for the coronary artery disease. This risk intervention trials, 6 of them are highly acclaimed. The first of all is one, that is the Framingham Heart Study. And thereafter the Stanford Heart Disease Prevention Program in California, North Karelia Project of Finland, the Oslo Study of Norway, MARFIT of US, and Lipid Research Clinic Study of California again. The major risk factors for coronary artery disease are the cholesterol, high blood pressure, smoking and physical inactivity. So most of these trials, they have dealt with these 4 factors only. First we talk about the Framingham Heart Study. It was started in 1948 in Massachusetts in US and now on to its 3rd generation in observation. So those on whom the study was started in 1948, those families ultimately continued in this prospective study, and now their grandchildren have entered into the observatory phase of this prospective study. It is a prospective cohort study, and it had found many relations and causal associations between the cholesterol, smoking and physical blood pressure and physical inactivity with the coronary artery disease. It is highly well acclaimed trial, and the results were reproduced in other setups in other countries. FHS, that is the Framingham Heart Study, risk score is calculated over 10 years on individuals for chance of developing myocardial infarction. The good score will be less than 10%, the intermediate score will be 10 to 20%, and high score will be more than 20%. In case a person has a high score, that is more than 20%, the chances of getting a myocardial infarction is very high. In the next slide, I will be showing you how the Framingham study score is being done. You can see in this Framingham point scores, a person who is around 60 to 64 years old got a point of 10, and his cholesterol level, HDL cholesterol level is less than 40, so he got 2, and his systolic blood pressure is 149 to 140 to 159, so he has got 2 points over there. And similarly, there are points on the total cholesterol, which he got 2, and he is a non-smoker, he got a 0. So his total score is 10 plus all the points have been added up, and it will come down to 17, and his risk score is just 5%. This is the way that you can find out individually the Framingham point scores and this percentage of risk of developing myocardial infarction in next 10 years. There are certain slides over here from the Framingham Heart Study which are internationally acclaimed. So here they have tried to show that with single risk factors there have been 43% of cases. With 0 risk factors, even 19% of cases of myocardial ischemia or heart attacks. And even with 2 risk factors, there are 29% cases. The next finding is the multiplicity of the relative risk with the multiple risk factors. Here on the left side, the relative risk is given, and on the right side with the yellow bars, the relative risk for the single risk factor, and with the orange bars, it is given the relative risk for the multiple risk factors. So you can see at the end of it, when a person is having all kinds of risk factors in his lifestyle, that the relative risk has gone up to 12. And just with smoking, single risk factor just with smoking, the relative risk is just 2. So the more the risk you have, the more the chances or the more the threats of getting a myocardial infarction or a heart attack. It's another finding of the Framingham Heart Study, where the relationship between the role of coronary artery disease along with the LDL cholesterol level and the HDL cholesterol level is shown. This figure is in a 3-dimensional graph. In the x-axis, the LDL cholesterol level. In the y-axis, it is given the risk of coronary heart disease after 4 years, and in the z-axis, it is given the HDL cholesterol level. You can see the highest level of the risk is in the tallest red bar, where the HDL cholesterol is 25 milligram percent and the LDL cholesterol level is 220 milligram percent. The LDL cholesterol normal level is supposed to be 130, which has got the minimum risk. So the highest risk is with LDL 220 and HDL 25 milligram percent. If it is there for 4 years, then the chance of getting the myocardial infarction, the risk increases to 3. Similarly, here we have they have given findings of relationship between diabetes mellitus and coronary heart disease. You can see if a person is having diabetes mellitus, for both men and women, the chance of getting a coronary heart disease is 17 per 1000. Whereas if the person is free of diabetes, then for male it is 8 per 1000 and for female it is 4 per 1000. Here also the multiple risk factors and relative risk for the coronary artery disease has been shown in a graphical form. The next intervention trial we come here as the Stanford 3 community study. It was started in 1972 in Northern California, US, in 3 towns, each having 10 to 12,000 populations. 2 communities were subjected to mass campaign for 2 years, and the 3rd community was taken as a control. The pre-campaign data on behavior and knowledge for coronary artery disease was taken. Emphasis on the diet, physical activity, smoking, blood pressure and serum cholesterol along with maintenance of the body weight was given. At the end, the risk of coronary artery disease estimated among the case and the control communities, and the risk was found 23 to 28% less in the communities who were subjected to the interventions. So the finding or the last word written in this, last phrase written in this particular intervention trial is that the community education has immense role in prevention of coronary artery disease. This is the North Karelia project. Further in continuation with the intervention trial, we are talking now about the North Karelia project. North Karelia is a county or a kind of province in Finland where the coronary artery disease is quite common. Here the population engaged are mostly the farmers, and they work in the forest and they live in countryside. The study was initiated in 1972 with the aim to reduce the risk factors, mainly the smoking, high blood pressure and serum cholesterol. The Karelia population were found to be great smokers. They are the male and the female population, both they indulge in smoking as well as they take lot of drinks. Early diagnosis and treatment was also a part of this study. The control community was selected from one of the neighboring county where the similar cardiovascular mortality was observed. At the end, the risk of coronary artery disease showed the significant reduction. By 1979, the risk declined by 24% in men and 51% in women in North Karelia. Here again, the community intervention and education showed the immense role in preventing the coronary artery disease by reducing the risk of coronary artery disease. Now we talk about the MARFIT or the multiple risk factor intervention trial. It is very well known trial. It is ambiguous. It did not produce the result as desired. Approximately 12,866 healthy men of 35 to 37 years were studied in US. 50% out of these were randomly selected and subjected to the intervention every 4 months to contain the risk factors. They are taken as experimental group. Intervention included cessation of smoking, controlling of blood pressure, dietary advice to reduce the cholesterol. Rest 50% of the community comprised as the control group. The control group did not receive any medical attention much, but however they were checked once in a year, and they were not given any kind of intervention, neither they were given any kind of advice. At the end of 7 years, it was found that the risk of the coronary artery disease showed 22% reduction in the experimental group. However, the same risk was reduced by 15% in the control group also. The reduction of risk did not vary much between the control and the experimental group, because the experimental group also unexpectedly followed the control measures. Because the experimental and the control group were from the same community, so they mixed with each other, they interacted with each other, and the control group found that the experimental group has been given certain lifestyle modifications or reformations which are helpful or which are beneficial to their life to prevent the heart attack, so they also followed. And that's the way the result of this Murphy trial was not successful. Next we talk about the Oslo diet and smoking intervention study. It started in 1973 with 16,202 Norwegians aged between 40 to 49 years. Norway is an Eastern European country, and here the coronary artery disease is rampant because of high smoking and alcohol use. 1,232 healthy smokers with high cholesterol level but normotensive otherwise were subjected to 5 years trial. Aim was to find if control of cholesterol and smoking could reduce the incidence of myocardial infarction. Dietary control and use of polyunsaturated fatty acids and cessation of smoking by counseling method were tried. At the end of 5 years, incidence of the myocardial infarction showed approximately 47% reduction. The study proved the primary prevention has a big role to play in the prevention of myocardial infarction. And last, we come to the Lipid Research Clinic trial US. It's a double-blind randomized clinical control trial. It started with 3,806 asymptomatic high-risk American aged between 35 to 59 years. The aim was to find if control of serum cholesterol by medicine could reduce the incidence of myocardial infarction. Men were randomly divided into trial and control group. The trial group received cholestyramine, that is the lipid lowering agent, and the control group received a placebo, which is nothing but some vitamins or minerals. At the end of 7.4 years, the trial group had 8.5% and 12.6% greater reduction in total cholesterol and LDL level respectively, and 24% reduction in occurrence of fatal myocardial infarction and 19% reduction in occurrence of non-fatal myocardial infarction. This particular study opened up avenues for newer drug trials to reduce the hypercholesterolemia, and after the cholestyramine, the statin groups came into play, and now, as you know, there are many kind of statins are being used to control the cholesterol level in the blood. With this, we finally come to the conclusion of this presentation. As such, you know, the CAD continues to be a public health problem in India. The death rate in India is quite high, and the pooled prevalence in India is 4.1 per thousand. An estimated burden of number of cases in India for a coronary artery disease comes around 5.4 lakhs. In India, long-term trials with large logistics has not been done so far, but Eastern Indian communities are more prone because they take rice diet, As such, use of salt, fat, oil, red meat, butter, clarified butter are rampant in India. Although rural people has a better lifestyle, but urban India is still in a risk, and the urban life is highly incriminating. There is a need in the national front to disseminate the awareness on coronary artery disease to prevent the coronary artery disease through the primary prevention. Primary prevention helps prevent coronary artery disease. One can age even with a young heart. Thank you.